This time. Hi guys, sorry, welcome to the sessions. We're just gonna let a few more people join and then we'll kick off. All right, we've got plenty of people joining us, so thank you everyone very much for giving up an hour of your time on a Monday evening. Hopefully it's not going to take that long. Welcome to the surgical sessions from Mind the Bleep. This is a brand new initiative that we're running at Mind the Bleep. It's been designed by surgical FY2s with the idea of giving you all the knowledge and information you need to see surgical patients as an FY1, because there are things that we feel we weren't taught properly and that we could have used a lot more experience in, that someone just could have let us know a few basic things. And so we designed this course with that in mind. So if I just move on to talk slightly more about the course, so that's exactly it. It's designed by recent FY1s for incoming FY1s. We're not going to be fannying around with the pathophysiology of the sodium gated ion channel, whatever nonsense. We just want to give you the core info you need so you can go into your surgical job really confident and smash it. We're super happy to answer any questions. We're very friendly. So if you have anything that you want to feed back from the session, or you just want to get in touch, ask something specific, please do email us on webinars@mindthebleep.com. The other thing is that we do need your feedback. So please do give us a shout at the end. We've got a QR code and you just scan that on your phone and fill in the feedback. This is so that we can make the session as good as it can be for you. And ultimately, we don't want to waste your time. We're not here to waste your time or our time. We just want to give you everything you want. So if you want more questions, you want more cases, you just let us know on that feedback form and we will make it so. The general format of these sessions is going to be defining the disease and the things that cause it. We're going to briefly whiz over the anatomy normally and a little bit on the pathology, but like I say, the bare minimum you need to make you safe and competent when you're dealing with surgical patients. We're then going to address really key things when you're actually seeing surgical patients, like the clerkings, the history and the examination, the investigations that you'll want to be ordering and considering. And then we'll go into initial management. Now, obviously, as a surgical junior, you're not the person making the big management decisions about the surgical patient. However, there are basic things that you can do that will really enhance the patient's care and actually, you know, in some cases, really save their life, you know, talking about antibiotics in the first hour and things like that. And then we'll end all of the sessions by talking about complications of the things that might happen in surgery. We'll talk through a case in every session, and then we'll have some little feedback questions at the end. So without further ado, this is me. Hello, my name's Ben Turner, not really Benedict. I'm an academic FY2 and I'm interested in HPB, vascular, a little bit of research and especially teaching. And as I said before, there are four of us who have set up this course for FY1s. And it's because basically we felt nothing was out there for new starter FY1s when we were in this position last year. And so we've set up the course to try and fill that gap in the teaching. So the key learning points for this session are going to be understanding the presentation of acute surgical conditions, the key parts of the surgical history and examination, understanding key surgical investigations and which ones to order when, And then we'll practice applying those skills throughout in a little case that we've got. So with all of these sessions, I want you guys to get into your head that you're the surgical FY1 and you're on take because maybe the SHO was off sick, or in your center, FY1s are expected to do surgical take. It varies from place to place. Just keep in mind that this is the focus we're taking when we're going through. So this is how we're defining what information to try and get across to you. So you're the surgical FY1 on take when? You see this chap, Jason. He's a 36-year-old male with no past medical history. Since this morning, he's been unable to eat very much, and he's got this grumbling central abdominal pain. It's pretty sore to touch, he says. He's been sick once, and feeling very nauseous, but other than that, he hasn't been too bad. And he feels a bit hot and sweaty, a little bit shivery. Okay, so that's our case that we're going to be thinking about as we work through today. When you're approaching these cases, there are key things during your clerking that you need to try and work through. So in this session, we're not going to work through a specific presentation. We're going to work through acute abdomen as a whole. And as part of that, we're going to go through the clerking in quite some detail. So first of all, we'll be talking about history taking and the sample history specifically for those of you that haven't heard of that. We're going through an examination with an A to E approach, and then we'll be talking about investigations, the bedside, bloods, and the radiology. So key questions in surgical history are always going to, these are basic questions that you should ask every surgical patient and should form the core part of your clerking. So it's always going to be nausea and vomiting, whether there's any blood, how much vomit, how much blood, coffee grounds, things like that. That's what we mean by the quality of the vomit. Then when you're talking about abdominal pain, Socrates, basic stuff, but actually the side onset and character of the pain are going to be some of the most useful discriminating questions in your surgical history. You know, if it's a colicky type pain that comes on over a few hours and then wears off again, you know, that's the sort of pain that you get when a hollow organ is cramping around something. So that's a super useful marker of what the pathology might be. Similarly, if it's a sharp, sudden pain that comes on out of nowhere, that leads you very much away from colicky stuff. So it's super useful. Bowel habit should always be asked about. The color of the stool, whether there's any blood, are they going more regularly, less regularly, have they passed any wind? All super important surgical questions. Jaundice, when we're talking about jaundice, we mean dark urine, pale stool, yellow skin, yellow scleral icterus, all very important as well. And then your constitutional symptoms like fever, weight loss, night sweats, rigors as well can come in under that. And that's important because a lot of surgical presentations are actually balancing sepsis. And so clearly those are symptoms that could be present quite often. So a couple of definitions for us to get our head around first. And I thought we'd start by defining acute abdomen, because when I started as an F1, they said to us, oh, it's an acute abdomen, but none of us exactly got what that meant. And what they're trying to say is a sudden onset of severe abdominal pain over a very short amount of time. And it's not like, it's not this sort of, oh, I've got a sore tummy and it's been getting worse and the pain's moving around. It's really severe abdominal pain. The patients look in pain. Quite often they might be tachycardic from the pain. And so they're quite useful markers to just from the end of the bed have a look and think, well, does this person actually have an acute abdomen? The acute abdomen itself is different from peritonitis. So peritonitis is actually a sign that is, well, peritonism is a sign that's elicited when there's peritoneal inflammation, and it causes rebound tenderness or percussion tenderness and also rigidity. So you can have an acute abdomen without peritonitis, but peritonitis is an acute abdomen, if that makes sense. So abdominal pain in general, we were talking about the site of the pain, and you can see here, I think, from this diagram, just how important it is to qualify the site of the pain. So you've got your classic causes of right upper quadrant pain there: cholecystitis, biliary colic. You've got your central causes like pancreatitis, perforated ulcers, and various other things as you move around the abdomen. Again, this is something that history taking can be less useful for, because patients will describe all sorts of places as saying that upper abdomen. They might think their upper abdomen is actually, sort of the suprapubic region, and it's best to verify exactly where the pain is by doing your examination. And with abdominal pain as well, we've got all those causes on the other page, but it's super important not to forget the non-surgical causes. DKA, Addisonian crisis. There's a whole load of stuff you'll find when you're on take that A&E will try and refer to you, because all they want to do is get people out of A&E within 4 hours. And it's important when you're receiving that handover just to be a little bit critical of what they're saying and make sure you've elicited some of those key questions in the history. So on to the abdominal exam. So whenever you're examining a patient, whether it's medicine, surgery, ITU, ED, it's all the same. You're going to use that A to E approach: airway, breathing, circulation, disability, and exposure. And by following that same pattern every time, it allows you to be super thorough and elicit all the appropriate signs. So with our patient that we were talking about earlier, Jason, our 36-year-old male with sort of general abdominal pain, his airway is patent and he's holding his own. His breathing is okay, but he's breathing a little bit quickly. He's got a rest rate of 22. His oxygen sats are absolutely fine on air, and he's got good air entry bilaterally. On his circulation, his heart rate's 104, so he's a little bit tachycardic. His blood pressure is 110/70. His cap refill's a bit equivocal at 3 seconds. And he doesn't have a catheter at the moment, so you don't have any urine output. Disability-wise, his GCS is 15 out of 15, his pupils are equal and reactive, and his blood glucose was fine on a venous gas. His exposure-wise, so he is febrile at a temperature of 38.6, and he's also guarding actually now in the right iliac fossa by the time you come to see him. And when you're examining, you do your percussion, and you can see that he does actually have some percussion tenderness that you think might be consistent with some localized peritonism. So that's Jason's exam so far. I just thought, given that we're doing a sort of briefing on surgical patients and how to approach the surgical case, we should talk briefly about the PR exam, because it's something that I was always a little bit afraid to do for patients when you're not sure whether or not it's going to be indicated, whether or not someone else is going to ask for it. So we've listed the indications for a PR exam here. Now, it's not exhaustive, but it is also relatively thorough. So you should always be doing a PR exam if someone is presenting with an acute abdomen and constipated, because the odds of it being a bowel obstruction or something like that could be quite high. And even if it is simple constipation causing abdominal pain, it's useful to know that with the PR exam, okay? You shouldn't use abdominal x-rays to diagnose constipation. So best practice for diagnosing constipation, and in fact in the NICE guidelines as well, it does say that you should perform a PR exam, even if it's not always done. Obstipation or not passing wind is very much the same. You could be thinking bowel obstruction in this case. And so a PR exam is critical, because if you're trying to confirm the diagnosis of bowel obstruction, you want to see that there is no stool in the rectum. Upper GI bleeds, you're looking for melena on your PR exam, and lower GI bleeds, you're looking for presence of blood as well. Tenesmus is a red flag symptom for anal cancer, so should always have a PR exam. Generalized guarding, where you're not sure of the source, but the patient looks quite unwell, they should always have a PR exam as well. Any change in bowel habit or urinary retention, you know, constipation is the #1 cause of urinary retention. Any kind of incontinence going on from that, because obviously fecal incontinence can be because of constipation, it can be overflow, and urinary retention can also be due to urinary obstruction, for example, and so you can have urinary overflow incontinence from that as well. Perforated viscus, again, you don't know which viscus is perforated, so a PR is generally indicated there. And then also you've got your medical stuff like back pain with a red flag symptom like, you know, bilateral sciatica. Okay, so that's something to briefly touch on. I think we'd say overall, the PR exam can seem a little scary to have to do, but it's relatively simple, and patients don't mind. Patients are quite aware that when something's going on with their bowel, they may have to have this exam. So, you know, that no one's going to be cross at you for having done one, but if you haven't done one where it's indicated, it could be tricky. Okay, so just having dealt with the history and examination there, I thought we should talk about the red flags and when you might want to escalate to one of your seniors once you're clerking a patient. So if the patient has involuntary guarding, i.e. when you press on their tummy, they're so rigid and they're not tensing to try and stop you pushing around, that is a red flag, and that needs to be alerted to your senior urgently, because that it dramatically increases the chances of a perforated viscus. Similarly, if the patient has 10 out of 10 pain and is writhing around, that's going to be another indication to get your senior, like your reg, involved. And finally, if the patient's hemodynamically unstable, you know, they're septic, they're dropping their blood pressure, that's not something that you should have to deal with alone. And the surgical patients that are septic can become profoundly unwell so quickly. You'll need your reg involved for ITU and all these sorts of things. And you'll need their clinical experience for when you're dealing with these really sick patients. So in terms of the investigations that you need to get for surgical patients, we split it generally into bedside investigations, blood tests, and radiology. So this isn't an exhaustive list here, but these are the things that your job as the FY1 on surgery is going to be to sort out. And this is probably what we'll spend the majority of our surgical placements doing. So bedside tests. Everyone coming through the door of A&E needs an ECG. You know, if they're tachycardic, they must have an ECG to rule out a medical cause on top of their acute abdomen, because it is seen and it does happen. Also, when they come through the door of A&E, they should have a lateral flow done, or a COVID PCR, a rapid COVID PCR equivalent. You're in the present day and age where COVID has been associated with such poor surgical outcomes, even for minor surgery. It's critically important that we know the COVID status of the patient. And your first step to doing that, before you talk to your reg about a patient that may need to go urgently to theatre, is you need to make sure that they've got that COVID swab done and that they've got a negative lateral flow to set them on the clean pathway to theatre. So it's super important. All surgical patients should have a urine dip, and that's because it can give you some useful information about protein or ketones in the urine. It can also help you rule out other causes of an acute abdomen, for example, pyelonephritis. You know, you might get a positive urine dip there, and that would lead you away from some other kind of surgical cause, and you could nicely refer to medics instead. All women under the age of 50, or if they haven't gone through menopause, must have a urine pregnancy test before admission to the hospital. Okay. It sounds super basic, but it gets missed all the time, and patients will make it to the ward. They'll make it to ultrasound or CT without having had a urine pregnancy test. And if a pregnant lady gets a CT, it's an absolute never event. So it's just worth bearing in mind that that's something you need to ask the ED doctors or the ED nurses to do. Blood tests for the surgical patient. So this is a pretty good list, actually, of every blood test you should be ordering for your surgical patient that you think is going to come in and go to theatre. So quite often the emergency doctors, when they're referring, the nurses will ask them what blood test to order, and they'll do your standards. They'll do your full blood count, your urea and electrolytes, your liver function test, and your CRP, which is good. But for these septic patients, they need magnesiums, they need calciums and phosphates, so the bone profile. Every surgical patient should have an amylase, or every acute abdomen should have an amylase, and that is to rule out pancreatitis mostly. You'll find with general intra-abdominal pathology and intra-abdominal sepsis that the amylase is raised, okay? It's quite a non-specific marker in terms of that, but it won't be raised to this level we talk about of 3 to 5 times the upper limit of normal, which is diagnosis of pancreatitis. Group and saves. Every patient who is admitted to surgical ward is going to need at least 2 group and saves. And before anyone goes to theatre in the UK, they have to have a clotting on the system. So that is your pretty good list of surgical bloods that you need to consider. Obviously, on top of that, you've got things like your venous blood gas. Now, some might consider that a bedside investigation, or I know it's a blood test, but that gives you critical information about the acid-base status and the lactate. And you'll find that surgeons have quite a low threshold for concern with regard to acidosis and things on the blood, because it unlike in medicine, the patients can become profoundly unwell very quickly. So onto the radiological investigations. Every acute abdomen is going to need an erect chest X-ray, and that is to look for air under the diaphragm. They're also going to need an abdominal X-ray if you're suspecting perforated viscus. You can also use an abdominal X-ray, as I was talking about, to sort of diagnose constipation. It shouldn't be used like that, but when you're using it to check that they're not obstructed because they haven't passed wind and they're distended, etc., that is a reasonable thing to do. The ultrasound abdomen is very helpful actually for surgical patients because it gives you information on the biliary tree and the gallbladder. It can give you a bit of information on the liver echo texture. You can sometimes see the pancreas based on the body habitus of the patient. And it's also useful for kidney and bladder and ureter pathology. So it is worth bearing those in mind. And obviously the ultrasound abdomen is good because it's a no radiation investigation. Can be used for appendixes, but as we'll discuss later, you can sometimes run into trouble requesting ultrasound abdomens for the appendix with radiologists. Everyone likes to joke about surgeons being heavily dependent on CT to diagnose their various pathologies. I think it's not an unfair comment. It's just worth noting that they always said CT, get a CT this, get a CT that to us. But at the very start, we didn't know which ones to order. Now, the one you're going to be looking for is a CT abdomen and pelvis with contrast, because the contrast highlights the walls of the organs that you're looking at, of hollow viscuses, etc., etc. So it is super important that it's with contrast. You can do a CT abdo-pelvis without contrast, and you would do that for patients that have very poor renal function. but it's not very helpful. So it's definitely worth discussing with your senior before doing that. Other investigations that you may have to get on surgery include CT angiogram, MRCPs for looking at the biliary tree as the highest sensitivity for diagnosing gallstones, and a CT-KUB for kidney stones. So back to our case again. We can see on the bedside test, the urine dip is +1 for blood and +1 for protein for Jason, but it's negative for leukocytes and nitrites. The blood tests, white cell count 12.1, CRP is moderately raised at 47.6, and the amylase is 129, so that non-specific marker of abdominal inflammation that we were talking about, that's slightly up. Radiology have unfortunately rejected the ultrasound abdomen we were requested to verify whether or not that appendix was inflamed. So the key assessment points that we've got so far, the key things that you really need to elicit in your history exam investigations are the type of pain and the character of that pain that we were talking about earlier. Those three key points, site, onset, and character, are really going to narrow down your differentials for the surgical patient. The associated symptoms they have, so that might be change in bowel habit, it might be jaundice, might be nausea and vomiting, lower or upper GI bleed. Always worth noting those extra symptoms. The examination findings of where the patient's tender. The blood test that we've got, so always looking at the CRP and white cells on surgery, and plus minus any other tests relevant for the pathology. Like if you've got hepatobiliary pathology, you're extremely interested in the liver function tests. And then we'll move on to the imaging. So what the results of your, or how the results of your imaging verify your differential diagnoses. So it's just worth us touching quickly on getting scans, because for me, it was always the scariest bit of the job, okay? And it's the number one thing you have to do as the F1. You'll be shooting around in your ward round in the morning, and the consultant will say to you, oh, can you just go and vet the CT straight after the ward round? So you go down there holding a piece of paper, quivering, terrified about the radiologist who's about to tear you apart. And they can be extremely fierce. I remember there was one who I don't think he ever approved one of my scans, but then I may have been doing things wrong as well. So they can be fierce, but don't be afraid of them. The way to deal with them is to keep them on side by phrasing your questions as, and for my learning, what would you recommend me doing next time? Or what are we looking for with this test specifically? Or how could I have made that referral a little bit better? So tips for successful scans, as we're talking about, always discuss them with a senior first and check that you know the indication for the scan. It's also helpful if you have that background knowledge of knowing why the scan is generally useful. So you could say, ultrasound abdomen, please, query choledocholithiasis, query dilated common bile duct, for example. And that lets you know, that lets them know why you're doing it. The best stuff to do is to maximize the clinical detail you're giving them. So instead of just saying, well, I'm looking for common bile duct stone, you need to tell them why you're actually looking for it. So the bilirubin is raised at 57. The ALP is also up at 217. Okay, that by giving them the biochemical details to allow the radiologist to narrate the story in his own head as you're going through, you're going to maximize your chances of them approving your scan, because they're going to agree with you that, yeah, you do need to do this scan in order to make this diagnosis. Describe the situation, describe how the patient is. Normally, if your patient's very unwell, the radiologist is actually quite understanding and will help you try and get the scan, and will suggest, or no, well, maybe you should actually be looking at this as well. And that's happened quite a few times. Always state your query at the end, what it is that you're suspecting or what your differential diagnosis is, because otherwise they may well reject it. And if it is rejected, don't be afraid to go and ask. Just check why they've done it, and you'll build up your sort of portfolio of phrases that you chuck into scans to make sure that they're going to get accepted. So just briefly, most weeks we will talk a tiny little bit about the surgery that the consultant's going to be doing for the pathology we're learning about that week. It's not going to be boring detail about this, that, and the other. It's just going to be like the main stuff and the headlines to take away, like, oops, what happens if the surgeon accidentally nicks this or nicks that, or why might this patient have that complication after surgery? Okay, because it's one of those things, surgery, where it's an art and a skill that you learn as you go along, and obviously everyone in different training grades is learning, so things do go wrong, and it's quite important to just have a little handle on what those might be. So some of the very much a favorite question of the surgical consultant going round on the ward round is, what incisions this, you know, can you think of what previous operation this patient may have had? And so we've just got some of the most common incisions with their names here. You can have a flick through those in your own time if you want. Of particular note, I guess, the midline incision, the Koch's incision for access to the liver, and Rutherford Morrison typically for accessing the external iliac vessels during kidney transplant. And then each week we're going to be talking a little bit about the management, and we split the management down into conservative versus medical versus surgical management options. Now, obviously, as the F1 on call, you can start the first two of these without anyone else even having seen the patient. And general conservative measures that you need to go with are, you know, prescribing fluids for your patient, okay? Especially with surgical patients that are septic, they may have fevers, and be losing more water than usual. They're going to need maintenance fluid plus a bit of extra replacement. So prescribing something like Hartmann's is brilliant for that. Medical things, you know, it's going to be your sepsis 6, making sure your patient's got oxygen, making sure they've got antibiotics, etc., and doing all of that within the first hour. And then your surgical stuff is going to be your big things like your appendicectomy. So just a brief note on fluids, because I think this is something that's incredibly poorly taught in med school, and that you start playing with it on the job, and no one really ever goes into what should be used when. But generally, the surgical fluid of choice should be Hartmann's solution, because it is the most similar to plasma. It's worth noting that it contains a little bit of lactate, and that's why for your septic patients, or your perforated organs, or your ischemic organs, when you've got lactates of 7, 8, 9, 10, you shouldn't be giving Hartmann's then, because it's got extra lactate in it, and so it will contribute to the lactic acidosis that will be making the patient feel very unwell, which is why in those patients, the standard is giving normal saline and bolusing normal saline for hypotension. With normal saline, you can also replace the potassium IV, and that is useful, especially if patients aren't eating and drinking. But it's just worth noting that you can't bolus when you've put potassium into the solution, okay? 5% dextrose is another useful one. So the classic mantra was 1 salty, 2 sweet, okay? And that was, so 1 bag of Hartmann's with 2 bags of 5% dextrose over a sort of 24 to 36 hour period. And that covers the patient for their maintenance fluids. With dextrose, it's good because you can also give them a little bit of potassium alongside, and you don't have to overload them on the sodium front, because, you know, normal saline's got 154 millimoles of sodium. So it's a lot. It's, you know, much more than your daily allowance of requirement. Okay, so at the end of each session, we'll also go a little bit into the complications, okay? And we In this session, I'm going to deal with some really common presentations that you'll see post-op. So that's post-op fever and post-op tachycardia, which are actually pretty similar in the way they're approached and managed. Then you've got post-op constipation, which you'll be called all the time about, especially at 3 in the morning for some reason, where the nurse decides that the patient, for whatever reason, needs to be seen at that second for their constipation. I've still never figured out why that is. And a really important one is post-op pain and knowing how to escalate that. So post-op fever and tachycardia are grouped together because they're generally the same sorts of things that you're looking for. So tachycardia and fever, they normally swing together, and your differentials are going to be sepsis, whether that's a surgical site infection, whether that's a lower respiratory tract infection from pain of the abdominal incision and then not inspiring deeply enough and contracting infection that way. But equally, it could be something medical like a UTI. And as the FY1s on the wards, you guys are going to be the first line of defense in medicine. So it's important that you're thinking about these things, because otherwise the surgeons won't. But you've got all other differentials for fever or tachycardia, like pulmonary embolism. So obviously an important one to watch out for post-op. Things like alcohol withdrawal, we've seen on the wards before. But also, it's worth just bearing in mind that if it's right after the operation and it's a low-grade fever like 37.6 to 37.9, you can get the systemic inflammatory response to surgery causing that kind of phenotype. So do bear that in mind. Your key points for assessing this are going to be getting your A to E and then getting any micro samples that you can. So that will be 2 blood cultures, repeating a chest X-ray, making sure you've done the urine screen, because those micro results are going to guide your antibiotic therapy. Make sure the patient's had some analgesia and an antipyretic in these instances, and your best one for that is going to be paracetamol. Paracetamol IV is obviously not going to be thrown up, and nausea and vomiting can be a significant post-op complication. So also paracetamol IV has has a higher potency, and so delivers more analgesia. Your blood gas is going to be another key point to do in your tachycardic and febrile patient, especially if their respirator rates are up or they've got a new requirement for oxygen. You really want to see that arterial PO2, and you're also going to want to see your blood pH and lactate, just to rule out, for example, intra-abdominal sepsis from perforation after surgery. So repeat at this stage, if you're getting a gas, you may as well repeat your other investigations like full blood count, urine electrolytes, CRP, and just check the direction they're heading. And then finally, in these patients, once you've done your A to E, you've got your micro, you've escalated your antibiotics, and you've got a gas, that's the time to talk to your reg and say, listen, I've done all these things. And if you have done all those things, they're going to be super impressed. And then you've escalated to them and you've let them know what the situation is. Post-op constipation, very common again, and this is largely things like ileus, where the bowel's been handled in surgery, and so it takes a while for the function to be restored. But equally, you can't forget causes like pseudo-obstruction, and then over administration of opioids, and patients being in pain will also cause some constipation, especially if they've had some kind of rectal operation or anal pathology. That can definitely lead to people becoming constipated. Key points to think about are consider doing your PR, and we talked about the indications for that earlier. Always check your electrolytes to rule out pseudo-obstruction. Things like a low potassium can cause pseudo-obstruction really easily in the post-op patient who already has a little bit of ileus and his electrolytes are already a little bit deranged. Make sure you determine the cause of the constipation. So you go and assess the patient and you think it's most likely that they've been on Oromor 5 milligrams QDS, without any laxative for 3 days now. You know the cause, make sure you state it clearly in the notes, and then you know that because you've done that, it's safe to prescribe those laxatives. In prescribing laxatives, it's very important to use a stool softener and a stimulant, because if you use something like senna by itself, it causes the patient quite a lot of pain. By softening the stool at the same time, it allows them to pass their bowel motions without that increase in pain that the senna can cause. And then finally, if your oral stuff isn't working, then it's time for the suppositories and enemas. Post-op pain, I'm sure everyone has seen the WHO analgesic ladder before, but it does form the basis of the management of pain on the wards as well. So your differentials are anything from normal post-op pain that we all expect patients to have, to perforation and florid fecal peritonitis. So when the nurse comes and gets you and says, this patient's in pain, please can you come and see them and blah, 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 it's important to take it seriously, because you'll get that 1 in 10 where they just look a bit peaky and you instinctively feel worried. And at that point, it's important to remember your A2E, check their obs, has their blood pressure suddenly dropped and they become tachycardic at the same time as this pain starting. Get the antiemetics into them. Don't forget about your opiates, but if you're going to give them, make sure you've got laxatives, and never give IV morphine on the wards, because you'll certainly get patients that ask for it and it's not appropriate to give. It causes a marked increase in degree of respiratory depression compared to oral opiates. So I think that's everything for our first session on the acute abdomen and introduction to being a surgical FY1. This is a free surgical webinar series that we're running with Mind the Bleep, and it's going to be going for another 15 weeks after this one. Each session, we're going to be doing questions, we're going to be doing cases, and we're going to be looking at the core things that you need to think about when you're seeing the most common and the most serious surgical presentations on tape or on the ward. We've got a landing page on Mind the Bleep. You're going to be able to watch these webinars back whenever you want. And to accompany each session, there's going to be like an online information page. And that's just going to have basically everything we're talking about, but in a written form, so that should you wish to revise it or remind yourself of something we said, it's all going to be on there. So by doing this, we're hoping to create the first and a really useful resource for FY1s that they can refer to safely. And then if you have any questions past that, please just run it by us. We'll be so happy to talk to you and answer any questions you may have. Okay, we're all super friendly, and we're going to be monitoring the email because we want you guys to get as much out of this course as possible. We'd love you to give some feedback now. If you could just take a few minutes, and I'll leave the link up here for a second. Our next session is going to be on lumps and bumps next week. As I was talking about, visit mindthebleep.com/surgery for recordings of these webinars, our written content, and just give us an email on that email address should you have any questions. I'll leave the feedback code up here. Thank you so much for tuning in. I'm just going to check if there are any questions from the live feed now, because I can't see it at the time. So just give me a second. Okay, it looks like there aren't any, which is brilliant. If anyone has anything, just give us an email, write on the event page, whatever it is, we'll pick it up. Please do fill out that feedback code, and I'll be sure to post it on the event afterwards as well. Thank you so much for joining us, and we'll see you next week for the next session.